Do you want me to stay logged on?
Oh yeah, that would be.
Oh, yeah, that would be great.
Thanks so much.
Because Richard's coming in next, I think. Usually it's waiting in here.
I've
I've got the cover of my pen. What can I do for you?
Can you sign it?
Yeah. Yeah, you sent me my comments. I was like, yeah. Okay, sure. We might as well not put this on yet. Okay, so I'll do mental health check in metro now.
Yeah, you sign when you sign. Yeah, but you have to sign.
Yeah, I've got a next slide.
Okay, so you have to sign
Your video. Okay, cool. So do you want to do? Okay, I'll just do both of them.
Yeah.
Hello. Hey guys, how are we going? We've got 3 quick announcements, just to give you the news about what's happening. First of all, we've got our mental and sexual health night from Rounds. That's on the 8th of October, and that's a really interesting night for learning a bit more about how to take care of yourself and what advice to give to your patient, which will be really helpful later on. That's going to be 5:30 to 7 o'clock, and that's in Wallisworth. And they've got some really interesting speakers, which have real life experience in that. We've also got our Talent Quest, which is the second last social event of the year. That's going to be a really fun night, and that's on campus as well. If you do have any events, we'll be talking to you kind of individually if we know you're specifically talented. Then give an email to social@medsoc.org.au.
And do you know the debate topic?
No. Oh. And there's also a debate as well, which is an amateur debate, which is not dissimilar to college debating. And that's that men are more interested in sex than women. So get along to that, it'll be a really fun event. And we've got like sangria and fancy cheese and stuff, just because we love you. We've also got one more announcement to do with Med Show. We'll just get a video up for that. Are you on the very front? Okay. Can we have a reading about make a movie?
I don't want to update.
You don't know me. I don't think this is drop off. I mean, running separately. Just fucking drop off. And then you're like, okay, just drop off. Sorry?
The next lecture is
So, it's on campus.
does that matter?
And then,
Oh, sorry.
I don't know where you put it, dude.
You just gave me a link.
Oh. Yeah, you can just go.
Okay. Hi everyone. Alright, so as you all know probably by now, Med Show is happening next week from the 9th to 11th of October, so Wednesday, Thursday, Friday. Okay, wait. And also, so yeah, guys, tickets are selling out fast, so please buy them online now, and you can choose the best seats and everything. And it's all to raise money for the Leukemia Foundation. So please get online or go outside the library, and we'll be selling tickets there for you. Thank you.
starting here so Richard can do his bit.
How you going? I'll do that. It's about my busiest teaching week in the middle of session break.
Oh, really?
You know, it's crazy.
Crazy for me. I don't know. Only one lecture here. Have you got lots of lectures for those guys?
Yeah, and I've got 5 labs today and tomorrow.
I've got labs as well, but they're pretty routine for me. I've lost the lid of my blue pen, which really
Just your...
Ah, there it is. It's not mine, actually. It's on the overhead projector.
Listen, when I came in today, there was a student guide on the document projector. Does it belong to any of you guys? It's an aging and ending student guide that was here. Anyway, there it is. Okay. So do you do the tracks with them?
Oh, here they are.
Do you do the tracks with them?
They do pain, don't they?
Yeah, but most of the tracks are done in the upper box.
Yeah. So I sort of mentioned something like that.
Because the medicine is
When I was talking about what a crack is,
yeah.
crack cell, I showed them some of it.
Yeah, so they need to know a little bit about pain. The rest of it's not so.
Right.
Okay, guys. Welcome. Let's get underway. So this morning we're going to talk about the vestibular system. This links to a lecture you're getting from Professor Stephen Lord about falls in the elderly. So to understand one of the causes of that, we need to understand disturbances in the vestibular system. So if you've done the ear and cochlea, this is a lot easier to understand because they're closely related, but vice versa, if you've done this, then when you come to the cochlea, it's easier to comprehend. So this is a section through the head, the ear. We're concerned today with this structure called the labyrinth. It's also called the inner ear if you're talking about auditory functions. So we've got a outer, a middle, and an inner ear, and this labyrinth is actually a bony structure, quite small, only millimeters in size, and it's got vestibular apparatus, it's got the semicircular canals which are apparent on the external surface, has some other vestibular apparatus as well, and then has the cochlea in this spiral-shaped component. It's innervated by the vestibular cochlear nerve, the primary source for the afferent information to go to the brain. If we actually look inside the labyrinth, we can see that that bony structure, where they're called semicircular canals, they're actually really full circles, full loops. Okay, and there's a membranous sac inside, and it contains a fluid called the endolymph. Okay, and the endolymph is one of the unusual fluids in the body because it has a very high potassium concentration. Okay, normally outside a cell it's very high in sodium. By having a solution that's high in potassium, we actually set up a potential. So there's a membrane potential from this endolymph to the rest of the body of about plus 80 millivolts. The reason we think that we have this system is that then when you compare the difference inside a cell, about minus 70 millivolts, to this plus 80 millivolt potential in the endolymph, you've got a very big driving force of 150 millivolts, 0.15 of a volt, which will push positive ions, in this case particularly potassium, into the cell. So it's quite an elaborate system, and it's shared by the cochlea and the vestibular centres. The vestibular organs you can see a bit more clearly. Inside the semicircular canals, the sensors are located in these swellings called the ampullae, and then we have what are called the otolith organs, which are in the utricle and the saccule. Okay, and all of these are on that interface between endolymph and the rest, so they can harness that driving potential. If we look at the cells that actually do the transduction, and transduction is a word that means changing some form of energy into a different form of energy. For neuroscience, it nearly always means changing an environmental stimulus into an electrical signal. Okay, so we're going to use in the cochlea, we're going to be changing sound energy, mechanical energy into electrical energy. In the otolith organs, we're going to be changing effectively gravitational energy, potential energy into electrical energy. Semicircular canal, we're going to be changing angular acceleration into electrical energy. The same sort of cell does the job in each of those organs. So here are the hair cells in the organ of Corti. There are some outer hair cells and there's an inner hair cell. The key feature of all of these is that they've got these cilia projecting out on top and they're projecting into the endolymph. Okay, we have a similar setup here in the semicircular canal inside the ampulla. There are hair cells projecting up into the endolymph with these cilia. And in the utricle and the saccule, we've got hair cells, these blue cells, again, cilia projecting up into the endolymph. Okay, they also all make contact with a kind of gelatinous cap. It's a little bit different in each case, and it has a different name, just to make things confusing. But we have a tectorial membrane in the cochlea, we have the cupula in the semicircular canal, we have the otolithic membrane in the otolith organs. Okay, and so those small differences in geometry are going to account for the fact that some of those cells can detect sound. They can tell whether you're listening to music or listening to someone speaking, or they can tell whether you're turning your head, or they can tell you whether you're lying down or standing up. Okay, but the cells involved are very similar. It's their configuration here, how they interact with their environment, that makes the difference. So let's have a look at these cells. They all have this same basic plan. Some of them don't have a kind of cilium, but it doesn't make a big difference. The key point is we've got this hair cell. Here is the endolymph, so that's this region out here. So they're projecting up into the endolymph. Down here is the normal extracellular fluid, which has a potential of 0 millivolts. Here at the endolymph, we've got plus 80 millivolts. So that's giving us our big driving force, plus 80 to minus 60 or minus 70 inside the cell. The stereocilia actually are membranous protrusions. They're part of the cell. They're not, so they're called hair cells, but the hair is actually part of the cell. Okay, there's actin filaments in there which push up, make the membrane bulge up into those stereocilia. What that means is that we can have channels in the stereocilia, ions can flow, there can be depolarization because these are just a normal part of the cell membrane. At the bottom of the hair cell, there's a synapse. It's got to be able to talk to the rest of the nervous system. And so there are some vesicles here. When there's depolarization, we'll see in a minute, these vesicles confuse with the membrane, like we were talking about yesterday, release some neurotransmitter, activate the postsynaptic neuron, which will send that signal up the vestibular cochlear nerve towards the brain. Okay, so how does it work? Well, these stereocilia have channels in it. We talked yesterday about voltage-gated channels, which were involved in generating the action potential. We talked about ligand-gated channels that were gated by the neurotransmitter. This is a third class of channel. These are mechano-gated channels, so they're mechanically gated by movement of these stereocilia. And current understanding is that there are little filaments, little links between them called tip links, which are sketched in there. And those tip links are actually attached to those mechanoreceptors, so that when the stereocilia move, it exerts quite a profound force on the channel, and it just mechanically makes that channel open. Okay, in some ways it's the easiest type of channel to understand. You know, how binding a chemical, how does that make a protein open and close, change its shape? Here you are pulling on it, and it pretty clearly can twist it or change its shape to make it open up. So here, when we deflect in one direction, we're opening these channels. The main ion that comes in is potassium. Okay, the channels themselves are selective only for cations, so they would let in any positive ion, but because they're sticking up into the endolymph, the main positive ion that's there to come in is potassium. Okay, so potassium comes in. We don't really care what it is. What's important is that it's a positive charge, so it's going to depolarize the inside of the cell. It used to be minus 60. Positive ions come in, that's going to bring it up towards 0. When we do that, we can activate voltage-gated calcium channels. Okay, this should be a pretty familiar story. The voltage-gated calcium channels are going to trigger fusion of the docked vesicles with the membrane. They're going to release the neurotransmitter, diffusing across, activating postsynaptic receptors, sending an action potential up to the brain. When it bends in the opposite direction, then we take the tension off the mechanoreceptors, they close. It hyperpolarizes because of the action of the pumps, pumping out the potassium that's come in, and so we stop releasing neurotransmitter. Okay, so as it sways backwards and forwards, the channels are opening and closing and sending action potentials up to the brain. And this is the same in the cochlea, where you might be listening to music, or it could be in the semicircular canal when you turn your head. In each one of those cases, the bending of these stereocilia is opening channels and ultimately causing action potentials. So the real trick is, how do we make these hair cells operate differently? This is an enlargement of the ampulla, that's that swelling inside the semicircular canal. What it shows, not exactly to scale. I think here are the hair cells, here are the stereocilia projecting up into this gelatinous cupula. Okay, the cupula has a density very similar to the endolymph, so it's effectively floating there, and there's no force one way or the other on the hair cells at rest. If you turn your head so that you rotate the semicircular canal, so we're rotating it this way, what happens, of course, is that the hair cells, which are embedded in the bony labyrinth are going to move following the direction of rotation. The cupula and the fluid inside your semicircular canals is going to tend to stay in place. Okay, you've probably all done this when you were kids with your bowl of Cocoa Pops or whatever, or a cup of Milo. If you spin it around, twisting your cup, after a while, you can get a vortex going in your Milo. Yeah, you can turn it around, and if you stop turning it, the vortex keeps going for a while. Okay, we call that an inertial flow. When you first turn the Milo, the mug is turning and the Milo is staying still. After a while, the Milo catches up to the mug, and then when you stop, the Milo will keep going for a little while. Exactly the same thing is happening inside your head. When you turn your head in one direction, the hair cells are forced to move, but the Milo, the endolymph, stays in place. Okay, it's going to be there, and depending whether you are looking from the point of view of the cup or from the Milo particles floating on top, it's hard to tell who's moving. You could argue that the endolymph is flowing this way relative to the hair cells, or you could say the hair cells are moving this way relative to the endolymph. Okay? Luckily, the brain doesn't normally wrestle with those sorts of questions. What happens is the hair cells are moving this way. That means the cupula is going to be pushed over that way. Its base is dragged along. The inertial flow of the endolymph pushes it to the side. That's going to open up the mechanically gated channels. The other thing which might not be clear to you is that the resting state of the hair cell, so positive, we've got a lot of depolarization. Negative, we've got it shutting off. The resting state is somewhere in between, where we've got some depolarization. So here we're actually able to signal rotation in both directions. One way we get more action potentials, in the other direction, because we're now closing those channels, we get hyperpolarization, we get fewer action potentials. Okay, so how they're actually organised in your head is a little bit complicated. So they actually, when you turn your head, in this case we're turning the head to the right, what they're sketching here is the deflection of the cupula based on the inertial flow of the endolymph, and you can see one cupula is deflected one way, the other cupula the other. And so in one direction you get an increase in firing rate in your right ear, and you get a decrease in firing rate in the left semicircular canal. If we turned our head the other way, we would get an increase in firing in the left semicircular canal, a decrease in the right semicircular canal. Okay, so they work as a pair in this sort of push-pull sense. One consequence of this is that damage to one of your vestibular organs is actually very bad. You start to feel the world is spinning, you have dizziness, you have vertigo, because you expect that balancing signal from the other vestibular organ. Okay, so loss of one is actually quite bad. It takes days or weeks before you adapt to having signals from just one. So often you have a few days of violent nausea and illness because of lack of that balancing input. Okay, so the semicircular canal, it's not getting sound energy, doesn't really detect gravity. That cupula is neutral, but it's perfect at detecting rotation. Not much good at detecting linear acceleration, because the fluid would be moving the same way on both sides of the canal, so there's no net flow, there's no deflection of the cupula. To detect linear acceleration, we need a different setup, which is called the otolith organs. Okay, we've got two of them. We've got the utricle, which is oriented in the horizontal plane. We've got the saccule, which is oriented in the sagittal plane, so this way. uses the same basic idea. We've got hair cells, they've got a synapse at the base, they're poking up here into the endolymph, they've got stereocilia, there's a gelatinous cap, but now this cap is embedded with otoliths. Okay, otoliths just means ear rocks, okay, rocks inside your head, and we all have them, and the main reason we have them is that they're much more dense, about 2.5 times as dense as your endolymph. Okay, and so that means that this cap, the otolithic membrane, is actually heavy. Okay, it doesn't float, it's full of rocks, it's heavy and it's sitting there. Why that's useful is that if we imagine this one, if we were to take the utricle, now it's sitting there, resting down on the stereocilia, not doing very much. If I tilt my head forwards, like that, or if I put my body forward, then it will now be oriented perpendicularly. The weight of the otolithic membrane will drag it down towards the ground in the direction of gravity. We'll bend the stereocilia and we'll send a signal up towards the brain. Okay? They can detect steady acceleration, so the force of gravity. They can also detect linear acceleration. So if we think about the utricle again, if I take a step forward, the inertia of the rocks, the otolithic membrane, will mean that my hair cells actually get bent backwards. If I take a step to the left, the base of the hair cells moves, but inertia deflects the stereocilia to the right. Okay? If I take a step this way, I'm dragging the base across, but the hairs will deflect off to the left. Okay? So I can detect linear acceleration, and by having them in these two planes, the utricle lets me do an X and a Y, the saccule lets me do a Z and a Y. Okay, so together I can cover all three axes of linear movement. My semicircular canals let me, I'm not sure which is the best picture, we'll see it in a lab in the next cycle, but the semicircular canals are orientated orthogonally to each other. We can capture all three types of rotation. So together we capture any sort of movement, linear or angular. This picture is trying to show you how the hair cells represent direction. This is in the ampulla, so this is the semicircular canal. And what we're plotting here are some hair cells. Here's the kinocilium. That's a big, particularly big protrusion. It's actually held up by microtubules rather than actin filaments. And it acts to give a direction. So bending towards the kinocilium or away from the kinocilium is the direction in which these stereocilia get activated. In the ampulla, they're all lined up the same way. So they all are activated by bending this way. They're all hyperpolarized by bending the opposite direction. And that makes sense. The semicircular canal is constraining that fluid flow to only go in one of two possible directions. Okay, there would be no point having the ability to detect movement in this direction when the flow in the semicircular canal, is only going like this. There's no point worrying about movement in the other axis. For the utricle and the saccule, it's a little bit different. And so here's a representation of how these hair cells are arranged. So here in the saccule, we've got some which detect movement in this direction, some which detect movement in that direction, some which go this way, some which go that way. Okay, the same in the utricle. We've got a mix of and forward and backwards, left and right. So we can detect movement in any direction. Okay, and that's set up purely by the geometry of how these cells are aligned inside the utricle and the saccule and then the geometry of how they relate to the outside. So whether they've got a canal around them which is constraining the fluid flow, or whether they've got this gelatinous cap which can potentially wobble in any direction. Alright, so we now understand the receptors reasonably well. We know what they're doing, what sort of signal they send up. Now we have to have a look at what the brain's actually going to do with this information. So the vestibular sense, you now are all experts on. You know that there are two drivers. There's the semicircular canals for angular acceleration. There's the otolith organs for linear acceleration. And not too surprisingly, they do slightly different things, and they go to slightly different targets. So here we've got the vestibulocochlear nerve. The first place it comes to is the vestibular nucleus, which is in the brainstem. Okay, and this is where the first point where things get rerouted actually occurs. Different pictures, so we've got another one here which shows the vestibular nucleus, and it's got lots of different divisions, but let's keep it simple. Focus on a lateral part of the vestibular nucleus and a medial vestibular nucleus. This lateral part is going mainly to the limb motor neurons and up to cerebellum, which is involved in motor planning. What do you think? Is that going to be more useful dealing with angular stuff or linear stuff? Can you see any reason why it should prefer one or the other? Yeah, why? Well, it's a major function of the vestibular nucleus is to just help us keep standing up. It's got an anti-gravity function. Okay, you know you can get the cerebral rigidity if you cut the brain above the brainstem but below the midbrain. What's happening there is that it's actually hard for us to keep standing up. We need to constantly have our leg extensors working, and that signal comes from the vestibular nucleus, from the lateral part. So here, the otolith organs are telling us which way gravity is. When you lie down in bed at night, you don't need to keep your legs out rigidly in front of you. You can relax. But when you're standing up, you don't want to suddenly flop down. So the otolith organs provide the predominant drive to the lateral nucleus, drive the limb, particularly the lower limbs in us, and cerebellum, because we're doing a lot of motor planning. The medial nucleus is then dominated by the semicircular canals. It's going to be dealing with angular type information, and not too surprisingly, it goes to our neck motor neurons. Most of our head movements are angular, okay? Not too many people can do the kind of Egyptian snake thing, so most of us are just turning our head, giving an angular component picked up by the semicircular canals. It goes up to sensory nuclei to let us know where our head is, and it goes to drive motor neurons. Why motor neurons? What would be the utility of that, do you think? Motor neurons for vision, extraocular. So, have some theories. What things control our eye movements, do you think? What sensors particularly feed into it? Vision, presumably. What else? Sorry?
I said loud sounds.
Loud sounds, they can actually. There is some effect from loud sounds. But there are two stronger drivers. That's exactly right. You don't want to move your eyes when you move your head necessarily. If you've chosen something to look at, your eyes want to stay on that target even as you move your head or as you move your body. So as I'm walking around here, I might need to avoid the desk, but I want to keep looking at whoever I've chosen to look at. My semicircular canals can detect that rotation of my head and my body and then send the opposite signal to my eyes to keep me fixing on a target. So the drives for eye movement are the visual system. You can track something moving visually. If you move your head, the vestibular system drives your eyes, and your motor system, you can voluntarily drive your eyes to do things. Okay, so there's three main drivers. Turns out the vestibular system is the fastest. If you've got damage to this, we'll look at this in a minute, you actually have a lot of blurry vision when you're moving. Okay, so this is complicated, but it gives you a good idea of how the vestibular system works together with the rest of the nervous system. So these are experiments. There's a monkey, and he's sitting on a table which can be spun around, but we can also, the monkey's been trained, he can turn his head around, and we can do some clever things. This is plotting the speed of the head, okay, so as he's rotating. This is the head relative to the body, so the monkey's just sitting still, so his head's not moving relative to his body, and we can see the table is spinning around, and that's causing the changing head speed. And so here's the prediction of the firing rate and the firing rate that we actually record. The prediction is the dark line, the firing rate is the grey, and the prediction is the dark line. When the monkey turns his head by himself, here he is turning it, he gets up to quite a good speed. We would expect that he should have a firing rate pretty similar to what we saw when he was turning passively, but in fact his firing rate is much lower. It's a little bit hard to see, but that low grey part. So he's actually got a lot less activity coming out of his vestibular nucleus than you would predict when he turns his head himself. Okay, so he's turning it this way. He has much less activity than when he was on a table, which turned at the same speed. And then we can do a trick. We spin the table in one direction. We get the monkey to turn his head in the opposite direction to try and cancel it out. So his head's staying roughly still. And then we see he actually has still some firing. Okay, he's got a depression in firing. And what that's telling us is that the motor system is actually sending inputs down to the vestibular nucleus to stop self-induced activity. Okay, it makes a big difference if the whole room starts shaking and I'm jumping around versus me turning my head. In one case, I don't care about it too much. In the other case, if the whole room is moving, I should be very alarmed and need to do something about it. Okay, so the motor system is projecting down to the vestibular nucleus, particularly this medial part, to regulate the outflow of what's going to the rest of the nervous system. The circuit that's involved in gaze control, and we call this particular reflex the vestibular ocular reflex, the VOR. There's a fair amount of detail here. I think you don't need to worry too much about the subdivisions of the vestibular nucleus, but here we've got the organ, we've got its ganglion, we've got the vestibular nucleus. There's a projection that crosses over the midline to the abducens nucleus, which is down in the pons. We've got a projection which goes from there back to the same side up to the ocular motor nucleus, and we've got a direct projection to one of the extra ocular muscles, in this case the lateral rectus. And so what happens is that we've got a fairly quick, not too many synapses. We've got the vestibular nucleus, we've got the abducens, we've got ocular motor, we've got the eye muscle. So a very simple and fast reflex, which is why we get such a fast response. What that response is doing, as we said, is that it's trying to make your eyes move in the opposite direction to which you turn your head. Okay, so here's the position of the head in space. This person is turning his head over to his, I don't know which way that is, I can't really work out, to his right. Here's his head position. No, to his left, I got it wrong. His eyes track in the orbit and do an exactly opposite motion, so when we look at his eye position in space, the point at which he's looking is unchanged. Because that connection is so short, we have a very fast latency, about 16 milliseconds or so, much faster than anything else. If things driven by vision are very much slower. What that means is that patients who've got damage to their vestibular system, when they walk, the world tends to become blurry. Okay, you've probably all seen in Halo or any other first-person shooter, when you run, the screen bounces up and down. Okay, it's a bit exaggerated, but that's what happens to us. When you run or when you walk, your head's actually going up and down, and we don't think about it. The world looks completely stable to us. But really, it should look like the screen of a Halo game. The world should be bouncing up and down, yeah? And the reason it doesn't is that the semicircular canals are detecting your movement up and down. They drive your eyes to counterbalance the movement. So as I go up, so I take a step, my eyes are driven down. As I come back down, my eyes are driven up. So that my gaze stays fixed in place. Damage to that system means that when you stand still, the world is perfectly sharp, but as soon as you start walking or moving your head, the world becomes a blur. Okay, so it's a very important system, one of those ones we don't miss, of course, till it's gone. Next year, I think we will spin you in a brownie chair. This is the sort of thing we would expect to see. So this is the vestibular ocular reflex. There's a subject who's sitting in a chair and being spun around in the dark. Okay? If we spin the subject to the right, we would expect their eyes to move to the left to counterbalance. Okay, and then of course you reach a point where you're at the edge of the orbit. You know, we can't do an exorcist and look out the back of our head or twist our head around. So you need to do something, and the solution is that we make a saccade to this side of the orbit, then we can slowly track across, then we make a new saccade, and that's what's captured here. You can see the movement at the speed of rotation is this slowly slanting line. The saccades are these steep lines. Okay, so this is a slow movement at the speed of rotation, hit the edge of the orbit, make a saccade. After about 20 seconds or so, you can see these eye movements go away. The reflex goes away. That tells us that the semicircular canal system adapts. Okay, the word is that it's adapted, it's not responding anymore. Why? Why would it stop responding? Think about your cup of Milo. We're spinning this person in a chair for about 20 seconds or so. Sorry? That's exactly right. After a while, the endolymph will accelerate to the same speed as you're rotating the head, so then the cupula will come back to that neutral position because there's no relative speed difference between the endolymph and the head anymore. When you stop the chair, then the person's eyes will go crazy again because the fluid will keep moving, the myelin keeps going around and their head's still, and you'll get eye movements in the opposite direction. Okay, so this is a reflex which shows adaptation. The odorless organs don't show adaptation. We can always detect gravity. Okay, so there's a couple of common things that can go wrong with the vestibular system. We'll talk about two of them. One is called benign paroxysmal positional vertigo. And what happens there is the otoliths, those small rocks in the utricular saccule, can actually get dislodged. Okay, they're just embedded in the gelatinous otolithic membrane. if they fall out, they can travel around the labyrinth. And because, remember, there's this big fluid sac which was connecting everything. So here they were down in the utricle. If they move into a semicircular canal, so they're pushing on an ampulla, that could potentially be bad. Why would it be bad to have a little rock resting on your ampulla in your semicircular canal? What would happen then? Can anyone imagine what that would do? It could be, but it's got there pretty gently, so it doesn't damage the stereocilia. It's just sitting there as a kind of weight. So normally the cupula is effectively floating. Now it's got a rock leaning against it. No, they're too small to block the flow of fluid. Well, it's like a weight, but it then depends which way the weight's acting. So if it's in your horizontal canal when your head's up, it won't do anything. But if you put your head back and now it's leaning on the cupula, it will push the stereocilia, it will deflect them. Okay, normally if I rotate my head, the semicircular canal fires, for a tenth of a second, then it stops. But now the rock is resting on my cupula, it's pushing my stereocilia. I'll keep feeling like I'm tumbling the whole time I've got the otolith pushing on that particular stereocilia. It won't happen if I put my head to the side or if I put it forward. It will only be in one position where it deflects the cupula. Okay, so you can diagnose which semicircular canal it's in by the position that evokes the vertigo. When the person puts their head to a certain position, suddenly they'll feel the whole world turning as though they were spinning in that direction. Because you can work out which canal it's in, you can actually work out how to get it back. You need to move it back to the utricle or the saccule, and so there's a thing called the canalith repositioning procedure. So depending where it is, there's a particular sequence. So here's one sequence where you have the subject, they go sitting to reclining, then they need to extend their head backwards 45 degrees. They roll onto their side, keeping their head angled down. Then they turn their head to the other side, and then they slowly come back up with their chin tilted downwards. And what we're trying to do is basically move the particle back along that track. And for most people, if they then don't do too many vigorous head movements, it will embed back into that otolithic membrane, and that benign paroxysmal positional vertigo will go away. Okay, so that's why it's benign. More serious is a condition called Meniere's disease. What we've got here, this is the fluid system that we've been talking about. So this is the endolymph here, the semicircular canals, the utricle and saccule, the cochlea. The endolymph actually has to be made somewhere. Okay, it's produced in the cochlea, and it normally drains out by the endolymphic sac, so down this way. If you have too much endolymph, if there's a blockage in its drainage, or if you're producing it at too rapid a rate, you cause the volume of the endolymph to increase, and eventually you can actually rupture the membranous labyrinth, so the membrane labyrinth inside the bony one. As you can imagine, that's pretty bad because it's high in potassium. Potassium, is what you give a lethal injection with to kill someone, but in smaller doses it's going to depolarize all of the neurons it comes in contact with. So the symptoms for Meniere's disease, so here we've got a normal labyrinth. Here you can see it swelling up as there's too much endolymph. When this ruptures, particularly depending where it ruptures, if it's in the cochlea, you'll have hearing effects. Semicircular canals, you'll have spinning. Utricle and saccule, you'll have sort of weird gravitational disturbances. Usually you get a mix of all of them. So it's a reasonably common disease, affects several people per 1,000. When you've got it, you tend to have a few attacks per month because the fluid builds up slowly and ruptures. The attack lasts for a few hours, then the pressure's relieved, but eventually it will build up and have another rupture. Each particular onset is very sudden and unpredictable, which means you can't drive when you've got it. When you have an attack, you'll suddenly have incredible dizziness and vertigo. You might have vomiting associated with it. Symptoms are apparently absolutely awful. In many people, it resolves spontaneously after a few years. It's not an easy condition to treat, but there are attempts by having a lower potassium diet to try and reduce the amount of endolymph that can be produced. Some of those diets seem to have some effect, but in general, there's actually not much that you can do. You need to be very careful. You tend to end up with some long-term damage to your hearing and vestibular system because that constant depolarization can actually kill the nerve cells, the hair cells that are involved. I wanted to finish up with a quick experiment. So I've got a theory about dream interpretation and the vestibular system. So the psychiatrists and psychologists have got their Freudian analysis, but I've got a physiological analysis. So I imagine most of you have had the falling dream. Most of you had the falling dream where you imagine you're falling and it's very scary, but you never actually hit the ground. Is that true? Okay. So let me ask, who here sleeps on their back mainly? Okay, we've got a few people sleeping on their back. When you have the falling dream, which way do you fall? Are you lying on your back, falling? And you, which way are you lying when you have the falling dream? Don't know? On your back, on your back. Alright, is anyone here who consistently sleeps on their tummy, so face down? Which way do you guys have the falling dream? Are you face down? So, I sleep on my back, so face down falling seems absolutely horrible. But psychiatrists might say some of you had a mother fixation, some of you have got a father fixation. I've got a much better explanation. Okay, so imagine this, you're lying on your tummy, you're lying face down, you're fast asleep. Your vestibular organ, your utricular sac, will tell you that you're lying face down. That's fine. All of your touch receptors adapt. They're rapidly or slowly adapting, but they all adapt. Okay, so they're not sending any information. You're lying face down, you know that, you don't have any touch information. That's all right while you're asleep. As soon as you just start to wake up, you start to get sensory input. Your sensory input says, I'm lying face down, nothing is touching me, therefore nothing is holding me up. The only logical conclusion is that you're falling. Okay, and the reason you can never hit the bottom is as soon as you move and say, oh, you move and activate all of your rapidly and slowly adapting touch receptors, and you work out you're lying in bed and the fear's gone away. Okay, and that's why we have a difference front and back. So you got the vestibular system and some dream analysis. Thank you. Yep.
About angular summary. Because I know why you left it, right? Yeah, I can actually understand this way how you understand differently. Probably the horizontal, if I'm moving closer, I'm actually moving. That's because of this. So when you move forward, the only ones which will be activated will be these ones.
that one is forward movement. So these particular hair cells and those particular neurons are connected, then you're moving forward. If these ones are active, then you think I'm moving to the right. If this one's going forward, if these ones are active, that means you're going forward. But they all have a slightly different orientation, that's right. So this is in the semicircular cow, it's easy, but it is not exactly the complicated. So you can tell and got it there. And then put them together to work out the same.
Are they actually sharing
yeah, they're doing the same thing.
the actual cap
The cap will done the same way.
but actually they will change the direction.
Yeah, it depends where they're trying to see in. So for one, doing this sort of thing, it will be trying to see it here, and then that would be detecting that movement. For this movement, it would be trying to see it here, and then the fluid will be so the hair cells have a different orientation of the fluid cell trying to see.
So you have no movement in this cell, this cell is quiet.
That's right.
Just just no adaptation. Thank you.
Yeah. Yeah, so if we think about the semicircular canal, so if this is it here, so you've got hair cells here. If you're saying you're going to turn your head to the right, okay, so this goes like this. No, so the bone is moving this way. The hair will tend, the fluid will stay still. The fluid goes the opposite of what your head does. Yeah, you're turning the cup, but the fluid apparently does the opposite. Because you're dragging the base of the hair, so the serious fluid will be left behind. You know, if you think about it like this, if I'm moving this, it can come that way.
I thought that is, are those the hair cells? Or is that the
That's the brain cell, that's the coupler, yeah.
So the ocular portion is very
Yeah, it's because they're embedded inside.
Okay, alright. And I didn't understand the monkey, not the monkey, this one.
So this is showing you the reflex eye movement. So his eye movement will actually be like this. There's a slow component. If he's rotating this way, the eyes will rotate intensely that way and then jump back. So it's like this. Okay? And so that's what this is showing. This is the, let's even see here, this is the slow component going like that. So there's a slow and then there's a fast component. Yeah, that's right.
And then it's sort of like...
And then after a while, the cupula is now, it was at first deflected, now it's come back to the rest position, so there's no more signal from the semicircular canal, so eye movement stops.
Oh, okay, so this is when he's already stopped turning.
No, he's still spinning, but, the fluid